So this is our April 2023 session of Community Health Learning Collective. We are so excited to have two amazing speakers from Access Living with us today. So I'm going to tell you a little bit about them. We have Alma Olavarría Gallegos, who joined Access Living in April of 2022 as the Latinx and Immigrant Community Development Organizer. And she works as the staff liaison for Cambiando Vidas. She holds a bachelor's degree in critical theory and social justice and has organized around race equity, anti-gentrification, and environmental justice. Prior to joining Access Living, Alma worked at Pegasus Legal Services for Children as a paralegal and training organizer, where she worked closely with monolingual Spanish-speaking families in New Mexico to obtain legal support. Welcome, Alma. Michelle Garcia has worked for Access Living since 2009, where she joined as the Latinx community organizer. She is responsible for increasing the number of Latinx leaders with disabilities and raising awareness in the Latinx community around disability issues, including immigration and healthcare. And in 2021, Michelle was promoted to the role of manager of organizing and community development and took on a new leadership position within Access Living's advocacy department. So two amazing speakers. Access Living, as you're going to learn, is an organization here in Chicago that works to build power among people with disabilities and works for better access and advocacy. So I'm so excited to have them here. As a CHW, as a person with a disability, I'm just really, really excited for these great speakers. So I'm going to now throw it over to you, Alma and Michelle. Welcome.
Thank you. Thank you so much for that introduction. I'm going to go ahead and start sharing my screen. And we have a presentation to share with you all today. I believe that while I share my screen, it's going to be a little bit hard for me to look at the chat. So if somebody has...
I monitor it.
Okay, great. If I don't answer it, it's because I don't see it, and we'll try to make sure we answer those questions. So let me go ahead and share my screen and pull this up. Oops. Here we go. Can everybody see? Okay, perfect. I see Maureen's thumb up. What we have here is I'm going to do a visual description of the slides just for full access. The first slide says presentation for HOP Foundation by Access Living, and it has a purple Access Living logo with like a water drop logo in purple. My name is Alma Olavarría Gallegos, and like Maureen said, I'm the Latinx and Immigration Community Organizer, and I use she, her pronouns. And Michelle, do you want to introduce yourself?
Sure, thank you. My name is Michelle Garcia. I'm the manager of community organizing at Access Living. Thank you.
Oops. Okay. And yeah, and this is Alma again. So first I want to talk to you a little bit about what's Access Living. We have been around since 1980, and Access Living has challenged disability stereotypes, protected civil rights, and championed social reforms. And I'm going to read what is on the slide so everybody has full access to what's being said, and then I'll elaborate a little bit on it more. So Access Living, we offer vital services, supports, and advocacy for Chicagoans with disabilities. Access Living staff and boards are comprised of more than 60% of people with all kinds of disabilities. And we're one of the first centers for independent living in the country. So one of the things I wanted to highlight is that we have a dedication to making sure that people with disabilities are getting support from people with disabilities. And we're really a proponent of self-advocacy, and that's something Michelle's going to touch on later, but I really wanted to highlight that as one of our goals at Access Living. Michelle also is going to talk later about what is a Center for Independent Living, but that's what we are, and there's 22 centers around Illinois, and we're the one that serves the Chicago area. What we'll be doing today is we're going to discuss what is disability, explore how perceptions of disability have an impact, discuss what is ableism, introduce independent living concepts, discuss how and inclusive environments that promote self-advocacy and lead to better long-term results, and talk about how to develop a disability inclusion mindset. I'm going to go to the next slide. And so these are some questions we're going to ask you all to reflect on. You don't need to respond to these questions right now out loud, but I do ask that you think about these and reflect on them as we go through this presentation, to just think about how this comes up for you. So the first question we ask that everybody reflects on today is, when you think of a person with a disability, do you have sympathy or feel pity for the person? So some of the people on this call might identify as people with disabilities, and if you do, you might ask that to yourself also about somebody with a disability that is different than your own. When you meet a person with a disability, do you see the person's disability before you see the person? And again, if you do identify as having a disability, maybe you can ask yourself, when you meet a person with a disability different to your own, do you see the person's disability before you see the person? The third question is, do you speak to and interact with people with disabilities different than you do with people without disabilities? If so, how and why? And the last question we'll ask you to reflect on today is, do you perceive people with disabilities as productive or competent as people without disabilities? If so, why? I've gone on to the next slide. And the next slide is just, what is a disability? I have a definition, one definition that we use here, but I wonder if anybody has a definition that they like to use, and if they do, feel free to put it in the chat. So what is a disability? To you, what is a disability? One of the definitions that we use most often is it's a physical or mental impairment that substantially limits one or more major life activities. Disabilities can occur on a spectrum. So they can be visible, hidden, or both. Disabilities ebb and flow, and they can be acquired at any age. So I'm gonna take a moment here to let people absorb that. Also, if people have a different definition of disability they like to use, I'll open up some space for people to add that in the chat so we can have some discussion around it. Okay, I don't see anything in the chat, so I'm trying to check.
No, there's nothing in the chat.
Okay, great. So I just want to highlight some of the main things that I said here. So first, disabilities can be physical or mental impairments. So a lot of times we think about a disability as something somebody can see. And I see this all the time in my work, is that especially around data collection, when I ask other organizations when they do data collection around if they serve anyone with a physical disability, a lot of data collection is based off of being visibly able to see that somebody has a disability, and not really off of someone self-identifying as having a disability. So I just want to highlight that physical and mental disabilities are not necessarily visible. And also they can occur on a spectrum. So that means that some disabilities can be more severe or manifest in a different way. And like I said, there can be visible disabilities, there can be hidden disabilities, or both. We're going to talk about that a little bit on the next slide. Disabilities can ebb and flow. So sometimes somebody like depending on a stage in your life or triggers that are activating a disability, disabilities can be more present or less present during certain times during the day or during certain depending on different external stimuli and things like that. And again, disabilities can be acquired at any age. So a lot of times we talk about aging separately, and yet also together along with disability. But what happens is usually as people age is they just acquire disabilities because it's more common to have a disability as you age. And so a lot of people who are older might not self-identify as having a disability, but might be part of the disability community as they get hearing loss or as their body changes, get these acquired disabilities that are really often associated with age. I'm going to go on to the next slide if there's no questions here. And then, like I said, disabilities can be hidden or visible. And so we're going to talk about what to know about invisible disabilities. I see Maureen put in the chat, it is so common for elders to acquire disabilities and does not self-identify as having a disability. Maureen, I think you're exactly right. And to your comment, I would also say that it's really common for people to not self-identify as having a disability. Just from stigma, we're going to talk about ableism a little bit later, but there's a lot of different reasons why somebody might not self-identify, but still have a disability. And that's really important to keep in mind when we're doing our work, because, well, we'll get into it a little bit later, because part of this movement is to create access and to create opportunities for everybody, not only people who self-identify. Okay, so what to know about invisible disabilities? Invisible disabilities are common. The CDC estimates that about 10% of the 61 million US adults that identify as having a disability have an invisible one. Likely many more unidentified or unreported cases of there are likely many more unidentified or unreported cases of disability in the US. People with invisible disabilities are protected by the ADA, which is American with Disabilities Act, and entitled to reasonable accommodations. Invisible disabilities can ebb and flow, and people of all ages can acquire invisible disabilities. So, oops. Sorry about that. I just pressed something and we went back a few slides. Okay, here we are. This is really important because like I said earlier, a lot of data is not collected around people with disabilities, but also a lot of, like, when we think about disabilities as being purely only based off of what we can visibly see in somebody, we miss a huge portion of the population. And there is a lot that we need to make sure that we're capturing, not only for data for funding purposes, but also for full access purposes and also for full rights. So I want to touch on a few things that we talked about. Invisible disabilities can ebb and flow. So one example of this is in my family, for instance, one of my family members has lupus, and it's not something that you can visibly see. Like my family member is really physically affected. It drains her strength on a daily basis. It affects her appetite, but it's not something that externally someone would be able to see. And in the Chicago summers, when it's really, really hot, she has to wear like full long sleeve and everything to protect her skin as part of the way that she helps her pain management, and gets a lot of like comments or looks around how she's dressed in the heat of the summer. And I know, because we talk about it a lot, that it affects the way she sees herself and how self-conscious she is when she presents outside, because that's something that she does, a different way that she lives, and in order to accommodate her disability, but that other people don't understand that immediately as what's happening. Another example, and so that's an example of a disability that ebbs and flows with the climate, depending on the climate, and that is also an invisible disability. Like I said before, people of all ages have and can acquire disabilities, which includes invisible disabilities. Another common one is like memory issues that happens. That's also kind of something that's going on in my family right now. And also as people have accidents too, those can affect not only the way they look, but also what kind of disabilities they have. So I'm going to touch on some core philosophical content and conflicts around disability. So I'm going to present two models, the medical versus the social model. The medical model states that disability is a diagnosis and the person with a disability is broken or deficient. So this model is the one that I think is really common to see, especially in the United States, but actually worldwide, as an approach to thinking about disability. The medical model is something that we see really employed within doctors' offices, where we talk about having a like an issue, and I'm using air quotes, as an issue that can be somehow treated medically, or that should be solved, quote unquote, solved in some way. And so that's when you think about, like, how do you think about a disability? And when you're thinking about people who have disabilities, do you think about what are treatment options, and do you think about how to eradicate or make the impacts of the disability smaller? So that's a medical model of disability. And a different model, one that we try to employ, is a social model of disability. And this model says that disability is about the barriers that society constructs, and the person with a disability should be accommodated. So, yes, Marian, I see a little heart here. So the social model of disability frames disability more within the context of the society that we're living in. Instead of framing an individual as being deficient for not being able to fit into the society that we've created, the social model of disability says disability is created because we've all agreed societally, maybe not explicitly, but we've all agreed to live within a society that has certain barriers and constructs, and is actually what is producing or highlighting this disability. And that there are ways that we could live or change within our society that would not create the same barriers that we have, and that would allow us to fully integrate or express or live to a capacity that we want to within our society. So I'm going to stop here, and I'm going to see if anyone has any reactions or questions about these two models.
I actually never knew the difference between the two.
Yeah, thank you for sharing that, Candace. I think it's definitely not taught very often. So it's something that is really nice to be able to name, because when you're able to name what's happening and able to name what kind of model is being used, you're able to name a little bit more about like what structures you're confronting, and just the vision that you have when you're thinking about yourself or others, or a population that has a disability. So yeah, thank you so much, Candace, for that comment.
I have a question. Do you think there's any work being done to educate physicians in the medical community on how to better integrate a social model of viewing the definition of disability into their work? I'm just curious because I feel like I have a daughter who has some disabilities, and in working with the physician community, it is always a medical model and often can be very overwhelming. And so I'm just curious, I would love to see in some of the medical community a little bit more of that social construct that you described so nicely. So I don't know if you have thoughts or any information about that, but I'm just curious.
Yeah, I mean, I think the disability, thank you for that question. The disability rights movement for a long time has worked on education in general. I know specifically at Access Living, we're doing some, one of our organizers who does healthcare work has been working on trying to integrate a more robust disability education system as part of the required training. I think, Michelle, if you'd like to speak to that a little bit more.
Yes, so this is Michelle. Part of the work that we do at Access Living, it has several components, right? So we try to educate organizations and companies as well as providers about the medical model versus the social model, so that you can integrate the social model versus the medical model. And to Alma's point, our healthcare organizer and our healthcare policy person who work together, they are working on developing a curriculum, or they're working with the hospitals. This is to develop a curricula that integrates disability into the studies that the incoming doctors are working on, where it shows medical model versus social model as part of their studies. Because we definitely see value in taking away, stop using medical model kind of thing, and be more inclusive of the social model, rather than keep seeing the disability as a diagnosis, and help, eliminate barriers. So yes, we are trying to, as much as we can, and when we can, to integrate this system or this model or these models into the work that the hospital systems and that are doing. I hope that answered the question. I'm sorry.
Thank you so much. Oh, go ahead.
No, I just was going to say thank you. It did answer my question, and I was just going to thank you for the work because I think it's really important and valuable. So thank you guys.
Yeah, thank you. Thanks for the question. And I think definitely as that work goes on, if you're interested in I think Maureen, I think you have been in contact with Ryan, but if you're interested in hearing more as that goes on and hopefully passes, if we need more support or something, I think that would be a great connection. I'm going to go to the next slide. If I can. Okay, yeah. So I'm going to talk about some core content conflicts versus care and support model. So then I'll read over the slide. The slide says who is really in charge, self-determination versus being managed, listening versus prescribing, person-centered planning versus manager planning, and the person with the most access to resources is not always the person who should be in charge. So this is another big philosophic conflict that we see within the disability community, which is what is care versus what is support. So this, I think, is something that is really relevant to the kind of work that you all do when we're talking about aging as well, because this comes up a lot. But the question of who is really in charge is really important to ask, because in our work, what we try to emphasize is a person with a disability is able to be autonomous and able to determine what is happening to their life and be able to be the one in charge of their own life. When I think a lot of times those rights for self-determination are really taken away based off of somebody's disability because of a preconceived notion that somebody wouldn't be able to or is insufficient in some way in determining what is happening in their own life. So we want to ask ourselves, when we're talking about care versus support, is who is in charge? And we also want to ask ourselves if somebody is able to have some self-determination, or are they being managed externally? So is the person with a disability able to talk about what they want and determine what they want for their life and make some goals and be able to realize those? Or are they being told, are they being managed, told what to do and what would be best for their life externally by somebody who maybe is interested in, maybe interested in them, that maybe has no ill intent, but it is trying to not allow some level of self-determination. This goes into, again, listening versus prescribing. Are we prescribing an idea of what we believe is a good life onto somebody else, or are we listening to somebody as they tell us what they want? Then there's person-centered planning versus manager planning. When we do planning for life plans, are those plans centered in the individual who has a disability, who is saying what they want, being listened to, and able to decide how they want to plan? Or is it being externally planned by a manager without centering the person with a disability? And then the last bullet point is the person with most access to resources is not always the person who should be in charge, which I think is really contradictory in our society. A lot of times we're told that if you have resources, it's because you've been able to gain them by some way, or you've merited the resources, and you should be able to make some determinations. But we really push back on that idea and just ask for some pause and thinking the person with the access to the most resources is not always the person who should be in charge. Sometimes because of what I just discussed, because of self-determination, because of the importance to center the person with a disability. So that leads us into our conversation about what is ableism. Ableism might be a term that is not familiar to many of you, but I'm gonna do some description here, and then I'll open up the space a little bit. So ableism is the discrimination of and social prejudice against people with disabilities based on the belief that typical abilities are superior. Ableism is rooted in the assumption that disabled people require fixing and defines people by their disability. Like racism and sexism and other isms, it includes harmful stereotypes, misconceptions, and generalizations of people with disabilities. So ableism is a part of our society, and we all hold ableist notions. We all are ableist in different ways, and that's just kind of ingrained in us because that's the society we live in. And I think also ableism is really broad, because even if you have a disability yourself, and you might understand the experience of what it's like to have your specific lived disability, there's so many different types of disability out there. You likely do not have all of them. So you probably in some way or another have inherited or have grown up in this culture that is ableist, and so have some ableism around other disabilities as well. So yeah, I'm gonna stop here and just open up to any questions around ableism.
Alma, I just want to make a comment, maybe while folks are thinking if they have any questions or if they want to put them in the chat. I think that ableism can include so many different things. So I just want to share one example that I think has come up a lot recently with the pandemic. You remember when we were in the beginning of the pandemic and everywhere you went, you needed to wear a mask. And now that they have powers that be have determined that there's not as much risk, most of those requirements have gone away. And so there are people, you know, who have disabilities that make them more susceptible. You know, they're immunocompromised. They need to be more careful that COVID could really impact them horribly. And so that's kind of an example of how like the status quo is kind of based on a quote, again, air quote, healthy person, like it's safe when it may not be safe, you know, to unmask for everyone. So I just want to kind of give that example of one way in which like ableism kind of like seeps in and people don't maybe realize it.
Thank you so much, Maureen, for your example. I think that's a really powerful and really pertinent example to what we see right now. I want to give another example of an ableist law. And this is a law called the Ugly Law that was instilled in Chicago. And there was like a ordinance in the 1800s that fined any person who was diseased, maimed, mutated, or in other ways deformed so as to be unsightly or disgusting. This was the verbiage used in the law. For appearance in public. So essentially, if you had a disability, if you were maimed, then you would not be able to be out and open in the public. And this was a law that we had in Chicago. So I mention that because like ableism, I just want to highlight that ableism has been around for an extraordinarily long time. And there has been active, legalized persecution of people with disability. And it's only been recently, fairly recently, that we passed the Americans with Disability Act, which still doesn't even afford all rights that people need. But yeah, so I just want to say that there's been a huge lack and silencing of education around disability, not only the disability rights movement, but also the history of disability discrimination. So you know, not to not fall into the maybe a kind of trap of being like disability has been invisibilized, where currently I think it's a little bit invisibilized, but it's also been continuously criminalized and continuously utilized as a way to kind of control a population, oppress a population. And that's the kind of history that we're dealing with when we're talking about ableism.
Alma,
Yes.
we do have a question in the chat. Someone is asking if a person with diabetes could be considered a person with a disability.
Yes, thank you to that question in the chat. And yes, to say the short answer is at Access Living, diabetes is considered a disability, and if somebody self-identifies as having a disability, that's kind of how our model is that we work off of at Access Living. So yeah. And another thing is that I would say a lot of people might not actively identify as having a disability. Even if, you know, so if we're to say Access Living, like if somebody has diabetes and says they have a disability, and then we say that, but you know, we don't, there's an issue, I think, too, with education around what is a disability, like, and also acceptance around having a disability, because people know and you know that it's much harder to navigate the world, especially I think in my work in Latinx communities, in marginalized communities. It's really hard to say that you and name you have a disability, because it means the acknowledgement of confronting so many more barriers, and also because there's an educational divide too, and just that language and that movement. Maureen, I see you put in the chat that eugenics comes to mind as well. And thank you for saying that. Yeah. So I'm going to go on to the next slide for the sake of time. Here's some language that we like to educate around. So, so I have 2 slides for disability language. Words to avoid are wheelchair bound, confined to a wheelchair. Instead, uses a wheelchair or a wheelchair user. Words to avoid is something that someone suffers from. Instead, use somebody has. Words to avoid would be diverse abilities, special needs, challenged, crippled, or cripple. And instead use people with disabilities or disabled. Words to avoid able-bodied, normal, words to avoid able-bodied and normal. Instead use non-disabled or a person without a disability. Some things to touch on is that, I'll just give some examples. I work with a lot of people who use a wheelchair. When I was talking about my family member, I said she has lupus. When I talk about people with disabilities, I say people with disabilities. For this one, I will say that there's a huge movement too that has reclaimed the word cripple or crip, and so not to necessarily go in guns blazing if somebody is self-identifying like that, but definitely do not identify somebody like that if they haven't already discussed that with you. There's and also, you know, it's more of a form of empowerment to be able to use words that have been historically leveraged against you. And if you don't have a disability, you would definitely, I would say, err on sticking with talking about people with disabilities instead of using different language. And I would also point out that diverse abilities, there's some language around different abilities too, diff abilities, that kind of just beat around the bush. And we really recommend that you just use language that is direct when talking about people with disabilities, not trying to cover anything up or try to make it more palatable. And then, yeah.
I see Green says the movie Crip Camp on Netflix.
Yes, yeah. And so that's an example of when the word crip has been used in a really as a way to kind of self-empower people. But Crip Camp is an incredible movie, and I definitely would recommend watching it. And then to avoid words like able-bodied, because again, not all people, if you don't have a disability, or how I would say not all people with disabilities express it. And so they might, be able, quote unquote, able-bodied. And that's not maybe the language that is encapsulating the message that you want to say. So if you're talking about somebody without a disability, just say a person without a disability. And there's one more slide on language. Words to avoid handicap parking. This goes for restrooms as well. Instead, use accessible parking, accessible restrooms. Words to avoid hearing impairment or visual impairment. Instead, use deaf or hard of hearing, blind or low vision. Words to avoid are mental retardation. Instead, use a person with a cognitive, developmental, or intellectual disability. And then I'm going to pass this over to Michelle Garcia.
Yes. So I will be talking to you about the independent living philosophy. So as part of the work that we do at the independent living centers, we've come along quite a ways. As centers for independent living, we have 4 core issue areas that we work on, which will be explained. But I wanted to share with you a quick 1-minute video. Hopefully I can click on it and it'll come out. Okay, there we go. And it shows what the independent living philosophy is. Can people hear the video? No. I don't think we can hear it.
I
What do
can't
we-
hear it.
Sorry, I was muted. Maybe this will work.
Independent living philosophy? Independent living philosophy believes that all people, regardless of ability,
Sorry, is everybody able to hear?
Yes, we can hear now.
Okay,
should have access to places, information, and opportunities that enable them to live independently and make their own choices on how they want to live their lives. No matter how we are built, whether we came this way or became this way, whatever our total set of physical and psychological abilities are, independent living philosophy says we're worthy, we belong, and we all have a right to be here. Independent living philosophy champions 10 key principles. 1, civil rights. Everyone has equal rights and opportunities. No stereotyping or segregation based on abilities. 2, consumerism. Each of us decides what's best for ourselves. 3, deinstitutionalization. No one should be institutionalized because of a disability. 4, demedicalization. People with disabilities are not sick and do not require a medical model of treatment to manage their lives. 5, peer support. People with similar experiences encouraging and sharing with each other works better than professional intervention in achieving independence. 6, advocacy. Community-wide change is needed to ensure that people with disabilities benefit from all that society has to offer. 7, barrier removal. Barriers of all types, communication, perception, and physical, must be removed. 8, consumer control. People with disabilities are best suited to run organizations that assist people with disabilities. 9, cross-disability. All people with all disabilities have access to services that support independent living. 10, inclusion. We envision an integrated society where all people with disabilities have equal access to important life opportunities such as education, employment, housing, and transportation. Independent living philosophy is a way of life, a movement defined by a set of principles that developed as a reaction and resistance to decades, if not centuries, of marginalization and mistreatment of people with disabilities. The movement gained momentum in the 1960s alongside the civil rights movement. And soon after, Centers for Independent Living were created to bring the key principles of independent living philosophy from ideas to actual practice and delivery of services. Over the past 60 years, laws and regulations, including the Americans with Disabilities Act, have been passed to provide rights and benefits for people with disabilities, and the work continues today. Socially, we continue to be marginalized and discriminated against. Beyond key ideas, independent living philosophy strives to change social opinion and stand up against overlooked injustice. Activist groups like ADAPT take social action to defend the rights of people with disabilities and an integrated community, while Centers for Independent Living are the living, breathing entities that represent independent living philosophy through services and community building activities. To learn more about a Center for Independent Living, watch the video, What is a Center for Independent Living?
Okay. As the video mentions, there's the 10 principles. We at Access Living have condensed them into like 4 key buckets, like advocacy, support, healthcare and support, the advocacy team, and the healthcare and support and services, which help people get out of nursing homes and into the home and community, like in the community, to live in the community. So our services and home and community-based services team, and then peer support. So we do that in different buckets, right? we have a legal team, which also supports the work that we do. And then we have the policy team as well that supports all of the work that, again, we do. And like in the video, it said, we are a center for independent living that is run by and for people with disabilities, which Alma also mentioned before. So it's very critical that we understand these key components. And like in the video, it also mentions that these movements have been around since for like over 60 years. You know, the independent living movement really gave a turn to us having what we have now, for people with disabilities to be noticed and have the rights that we have now, and laws that allowed us to have access to affordable, accessible housing, although we're still working on that. But to just have access to enter a building and be able to go to school. The first independent living center, the first center for independent living started at Berkeley, California. And that was because a gentleman wanted to go to school and the dorms were not accessible. So of course, he was like, okay, what do I do? They wanted to ensure that they were able to go to school and stay in the dorms. So they made a notion and they gathered a great number of folks, I'm sorry. And they made sure that they made it notice that the campus was not accessible. So now, years later, they created, well, in 1973 or so-ish, they created the first Center for Independent Living because they knew that the individuals that wanted to go to Berkeley and that wanted to live independently needed a center and needed supports. So that's how the first Independent Living Center got created. And now, years later, here we are at Access Living. We are the only center in the city of Chicago. Like Alma mentioned before, there's 22 centers for independent living in Illinois. We are the largest one thus far, and we are the only one that works on a lot of the issues that unfortunately a lot of our sister centers are not able to work on due to funding. So that's a lot to say about the work that we do. So let me continue. Like I mentioned, we offer peer support. So peer support is a process through which people share common experiences or face similar challenges, and they come together as equal to give and receive help based on the knowledge that comes through shared experiences. So for us, it's very critical to know that we feel very comfortable when we know someone that is going through our same experiences. I, as a person with a disability, feel comfortable sharing my experiences with others who have been through what I've been. So obviously I'm gonna want to talk to them and receive any supports or whatnot from that person. So definitely we practice peer support. In independent living practices, people with lived experience of disability help support peers with similar disability experience, which is what we just mentioned. Then of course, the presence of choices. People with disabilities have choices, right? We need and deserve to know the choices we have available to us. The choices should be communicated in an accessible way, including writing or verbal or any alternative print format or ASL or any other language. That is a must, as well as the removal of barriers. So they spoke a little bit about it in the video around ADAPT and about what they did And also when they created the sills, right? So again, because of the history of how the sill was created, we were trying to remove barriers so that some, people could attend, in this case, the university, or if we need to go somewhere, we need to make sure the barriers are removed. So it says here, it is important to identify and remove barriers that may be getting in the way of a person's choices. Flexibility, creativity, and respecting choice are key. So it's very important to respect choices, but also ensuring that the barriers that do not allow you to make your choices are removed. Presume competence. So it's very, very common that far too often people
I'm sorry, I didn't stop on the removing barrier slide, so I'm just gonna show that really quickly. And now I'm gonna move on. Could you tell me when you need to click through slides, Michelle?
Oh, sure, sorry.
No problem. Thank you. Sorry about that, everyone.
No
Go ahead.
problem, I'm sorry. So very far too often, people with disabilities, there is an assumption that people with disabilities are not competent. We are seen as, oh, well, they have a disability. They don't have a college education, or they can't work, right? And that's a very erroneous assumption, because we can work, we can go to school, we have degrees, we can get married, have kids, etc. There's all these assumptions and wrong thoughts around what we can and can't do, or what we should and shouldn't do. So it says here, far too often people may make assumptions about disabled person's competence. Always start by presuming competence. If something is not clear, ask the person questions to clarify. Find a way to communicate that is a two-way, not a one-way. So yes, if you have questions about my competency, ask me, don't just assume. Here we go. Can you go to the next slide? Thank you. Considering dignity of risk. So just as anyone else, people with disabilities can make choices about their own lives. As I mentioned before, we are able to make choices of our own life, how we want to live it, when we want to live it, how we want to live it, where. Sometimes the choices are good, sometimes the choices are bad, like everybody else with and without disabilities. But the choices belong to the person with a disability, not to someone else. And this happens way too often with people with disabilities, that we live with family members and family members because they care about us and because they think they're doing the best thing for us. They make choices on our behalf, and that is not, they don't even take us into consideration because they think we're not competent to know what we want. That is very erroneous and wrong about them or on their behalf. But again, we know that they're coming from a place of love, but also that they don't know that we can make our own choices, even if they're bad. We can make their choices. So just like anybody else, we can deal with consequences of our own choices. I can say for myself, I always have, I've lived on my own for years already, well, with my husband, but my family back home in Texas, they're always criticizing the fact that they think that I don't make good choices, but they can live with it. It's funny that they get worried about our choices, but I understand that it comes from a place of love. So promoting interdependence. So this is very key. We say always about being independent, but we're really not independent. We are interdependent. We obviously depend on folks to support us and provide any, like a key support. Like I'm not fully independent. I depend on others to be able to be here talking to you today, for example. And thank you, Alma, for going to the next slide. Sorry, I didn't tell you. So people may assume that independent living means that a person needs to do everything in themselves. That is not accurate. Independent living is really about people with disabilities being in charge of their own lives. If we need help, we ask for it. We are still making our own decisions when we ask for help. Interdependence is what some people will choose. It is all about consent and what we feel is right for ourselves, for us. So again, I live on my own. That doesn't make me independent. It just because again, what I mentioned, I need support to be living my day-to-day life. So I live interdependently. Next slide, please. Then remember again that the person with the disability is in control. Take the cue from the person with the disability. If the person with the disability tells you they need support or they want help, then it's okay to support them or help them. But if we're not asking for help, you don't need to necessarily go ahead and do things. We have the right to lead our own decisions that affect our lives. When the person with the disability feels they're not leading or being allowed to decide, the community transition may not be as successful as we would like. So it's very important, again, to allow the person to make their own decisions, because if the person with the disability feels they are not being allowed to make their own decisions, it feels kind of like we're being told what to do and we're not being seen as competent. Okay, next slide. And then the hardest question I think here, of course, and we talked about barriers earlier, but I want you to ask yourselves, have you been in a position where you think of yourself as the barrier? I mean, yes, you want to help and yes, you want to be there, but are you the barrier? So ask yourself regularly with kindness, are you the barrier? Are you thinking in such a way that promotes and encourages self-advocacy for people with disabilities or not? So are you encouraging the person, your loved one or person that the person with a disability that you were meeting with to be interdependent? Or are you just you want to do everything for them, thinking that'll be enough or that's helping them rather than not? Because that's a barrier rather than you helping them. So have that in mind, right? Ask yourself that if you're being a barrier. The next slide, I'm so sorry, next slide. I talk pretty fast, as you can see. So if you have any questions, please stop me. We're almost done, and so we can go for questions afterwards. Anyway. So developing a disability inclusion mindset. Alma spoke about this earlier a bit, and then now I want you to have, there's key things that when thinking about a person with a disability or meeting a person with a disability, you should have in mind. So developing a disability inclusion mindset means having no pity for the person, no inspiration. A lot of people come to me and say, oh, you're such an inspiration because look how far you've come. You've done so much. I always say, oh, thank you, okay. But I don't want you to see me as an inspiration just because I'm a person with a disability and I've done my work. I mean, I've done what everybody else does to survive and live and have some food on the table, basically. So, and then also have the mindset that disability is a rich and complex experience for most people. Disability inclusion is not a select few. most inclusion practices make things easier for everyone. So be inclusive. I mean, you might not say, oh, but we don't work with people with disabilities. But if you include in your work or in your general space, some accessible or in your activities, if you make them inclusive for everybody, you know, for people with and without disabilities, it'll make your work a lot easier. For like providing access for interpreting or access for people who use wheelchairs, it'll make the work easier. Ask direct questions related to relevant activities. Again, so if you have an activity that needs to be more inclusive, ask the individuals questions about how can we make this activity more accessible. Get in the habit of asking, how is the disability community impacted by X? So again, if you're doing an activity or planning an event, please get in that habit of asking, does this impact the disability community? And if so, how? Because more than likely it will. Any issue, housing, employment, healthcare, anything that you'll be working on is more than likely going to impact the disability community. Don't think that disability inclusion as a separate issue or a separate exercise, but as something that is to be incorporated into what you're already doing. Again, I know it's kind of redundant, but just incorporate what your inclusion into whatever you're doing already. And then of course, this is, I always say that this is the next one, the budget piece. I wish we should have highlighted it. So the budget piece is where it's very key. So I know I've worked with organizations and different entities. A lot of our organizations have smaller budgets than we do, of course. And so they don't have a set budget for accessibility or accommodations. But I really, really encourage you to set aside some monies, some type of budget, even if it's starting off at a small budget for interpreters, because you never know when you might need an ASL interpreter, or you never know when you're going to need a Spanish language interpreter for an event, or for a PA. So when we plan events, for example, at Access Living, we have to be mindful that we need access to a PA because people might need support. So if you have it in your budget and you plan it when you're planning all of your yearly, but you get your yearly budget, I'm sorry. You're like, okay, so we're gonna put aside $1,000, just a number, $1,000 for accessibility. You already have it set aside for that. You're not scrambling to like, oh, we can't be inclusive because we don't have interpreters or a PA. I hope that helped. And lastly, welcome people with disabilities and let them know what accommodations you offer. Again, this goes to the one above. If you offer accommodations like interpreting, PAs, you have an accessible space, you're gonna be where, you can tell the people with disabilities, we offer this or we offer that, and we're gonna feel welcomed. So you obviously want people to feel welcome in your space, at your events, so on and so forth. So that is my spiel. And now I want to open it up to questions and somewhat of a discussion, if you may. I know we went pretty fast, or I went pretty fast.
Thank you, Michelle and Alma. That was a lot of really important information in a relatively quick time. I thank you both so much for sharing this. We'll open it up for questions and comments. And I also just want to let people know that I do plan on emailing out the recording and sharing the slides, because I know that people might want to refer back to some of these concepts at a later date. But yeah, let's open it up. If anyone has a question, you can put it in the chat. You can also feel free to unmute and ask your question.